How is it that the wealthiest country in the world has such a screwed up healthcare system? After 35 years in the healthcare industry, I decided to retire and share my secrets with you. I'm Chuck Melindy, and this is Disruptive Dialogue. Hey everybody, Chuck Melindy with Disruptive Dialogue. I am very excited about today. I'll call him a colleague, but at the time he was my boss's boss and he ran the department at Johnson & Johnson. I want to introduce John Hoffman to the show. John was with Johnson & Johnson for 37 years in a variety of leadership roles from finance, marketing, strategic account management, corporate strategy. To me, John really was a visionary in that he pretty much launched and created and expanded our policy and advocacy team at Johnson & Johnson. It has been considered for years to be the leader in the industry as far as policy and advocacy goes. And so John comes on here with a wealth of knowledge. He's actually been retired just over 2 years, so he beat me to the punch. He's up in the Northeast. He's a proud dad and grandfather. He's now a budding author. He's already put out a white paper. He's writing a book, and he does a bunch of consulting across the board for biotech, medical device, you name it. And so I'm very excited to have John here today. But John, before we get started, we're both retired now, and I like to always say I'm having fun. So I've got today a beer, and I got a Tampa brew. It's a IPA called Free Dive. I was going to drink white wine with you, but my 24-year-old daughter, I think that she emptied the fridge of Sauvignon Blanc. So I'm hitting a beer right now. How about you, John? What do you have?
I have a glass of Sauvignon Blanc, and I'm not as particular as you in terms of I don't even know the brand or the origin. If as long as it's yellow, clear, wet, and got alcohol, meets my criteria. So cheers.
Cheers, John. I love it. Good to see you, brother. You know, John, if you can, I gave a little bio about you, but, maybe you can give a little more color commentary as far as, what you felt you got out of working at, Johnson & Johnson in the industry, and now what are you doing? And then we'll jump into giving everybody a little bit of history around the healthcare landscape.
Sure. Well, first of all, I'm not sure I can live up to that gracious introduction you gave me, but thank you. But yeah, 37 years with J&J, I actually started in finance. And then maybe we can talk about this in the history. When managed care and HMOs came around, I moved into the healthcare marketing space because my finance degree helped us cost justify our products, which we finally started to have to do. And then stayed in that area, and 20 some years ago got bit by the patient advocacy and policy bug and realized that the healthcare system, even back then, was starting to constrict and restrict access, and that we needed to make sure that the policies that were being put in place, both by the public payers, but more importantly, sometimes by the private payers, were going to not have an adverse impact on patient access to care and provider choice. And so that's what the last 20 plus years of my career were. A real passion for patient access, et cetera. And since retiring, I didn't really plan probably to consult or work or publish or anything, but that passion doesn't go away, as I know you share it. And some of your guests, your previous guests, Maddie Feldman and others have had that same passion. And so continuing to do that. And because it's important to me, not just from a philosophical perspective, but given some of my grandkids or whatever, it's personal as well. So that's what I've been up to.
Well, John, it's like I said, it's number one, it's a pleasure reconnecting. But where we are today, I think that we would all agree that healthcare is not ideal. It's a system basically that is, for the most part, run by publicly traded companies. Their fiduciary duty is to their stockholders or shareholders and not to the general public of who they are providing care in these services. And I think that there's a lot of laws that have been passed over the years with the best of intentions, but leading to unintended consequences. And so I think a lot of people that on this podcast, heck, when you started with J&J, weren't even alive. And even some that when I started with J&J weren't alive. So, we can go all the way back, but, just a quick history lesson, as you well know, in 65, Lyndon B. Johnson, he brought Medicare to us. And I think that was an amendment to the Social Security Act. And it was great. I mean, it helped a lot of people. From what I read and researched, they were depending on midwives and other non-healthcare professionals before Medicare really rolled around, because a lot of people could not afford to pay physicians. And so Medicare was huge. And then, it really didn't change a whole lot. I mean, there's different things and different aspects, and you can fill in the gaps until, to me, with George W. Bush and the Medicare Modernization Act in 2003, as far as big things that hit that changed the landscape. Correct me if I'm wrong, but I don't think that Medicare in 65 was even supposed to cover medications. But I think, didn't they bring it around because of insulin?
Well, the Part D benefit was established with the Medicare Modernization Act of 2003.
Yep.
So, yeah, for prescription drugs were not covered up until that point for Medicare beneficiaries. People could buy private insurance
Right.
For that, but nothing provided from the federal government until 2003.
Yeah. So, I do think, we can go back and forth, but, so Bush passed in 2003, the Medicare Modernization Act, which gave us Part D for Medicare beneficiaries, which I think was a wonderful thing. Then you had Obamacare, or the ACA, in 2010 that expanded Medicaid, among other things, and, really lowered the number of uninsured in our country. And then you've got, for the most part, the Inflation Reduction Act, and I'm skipping probably some smaller legislation, but the Inflation Reduction Act, which then really and truly addressed the rising costs in Part D by capping this year Medicare beneficiaries at $2,000 out-of-pocket costs for drugs outside of their premiums, and, negotiating with pharmaceutical companies around their drug prices, which actually repealed part of the Medicare Modernization Act. But anything I missed big during that time?
Well, I think you've covered all of the federal public policies, but I think the bigger thing that is having at least as much, or if not more, of an impact on patient care, patient access, drug prices, et cetera, is what happened in the private sector with the institution of managed care.
Yep.
Back in the 80s. I remember, I'm older than everybody else, the first health maintenance organization, or HMO. And I guess we should have all really been concerned when managed care came out. They tried to position it as managing clinical outcomes and safety, but it really was managing the dollar. And full disclosure, I'm a recovering accountant. I have an accounting degree. Those organizations were predominantly run by bean counters. I'm a bean counter, so I can use that derogatory term. And to your point earlier, we've now become, it's very much a for-profit, one of the most profitable industries in this country. And the profitability, not only of the insurance and pharmacy benefit management sector, but frankly, of the pharmaceutical sector as well, is what the biggest contributor, and also some of the providers as the contributor, and the hospital systems all contribute to the rising, escalating cost of healthcare, which has caused utilization management and managed care to be a necessity.
Yep.
Otherwise, no one would get care because they couldn't afford it. A lot of people are not getting it now because they can't afford it. But the problem is, a lot of those decisions are being driven by the expectations of investors, analysts, and Wall Street, because they don't want to see the industries become less profitable because they're making healthcare more affordable. It's kind of this weird dichotomy, but it's what we're dealing with, and I think one of the biggest contributors. So when you take that private market phenomenon, then you take what's going on with those public policies, and interestingly enough, my view is the restrictive things, like in the Inflation Reduction Act, negotiation, all those things, the things that restrict access and reduce costs, the private sector accepts willingly and mirrors what Medicare or Medicaid does. The things that expand care or open access, they're not as quick to follow.
Right.
And so I think overall, you're seeing a lot less access to care at a much higher cost to the patient.
Yeah, it's, and I appreciate it, because like you said, I really went down like the public payers landscape of policy, and you went down the private. And I do, look, at the end of the day, and this is a theme that I have with most of my podcasts, is don't hate the player, hate the game. I mean, you and I have both worked with people across all different industries in healthcare, and they're good people. And they're just doing what they're supposed to do. That's their mandate. To exactly your point, United, I think they went over $100 billion for Q1, and the investment community was unhappy because they weren't growing as fast as they normally grow. And that is an almost a dichotomy and a contradiction to what we want, which is we don't want your revenues to grow because that means you're charging us more. So, I think that maybe that allows everyone to see, oh my God, managed care has been around for a long time. And more than likely, and by the way, I can call them bean counters too. I don't know if you know this, but I graduated from the University of Florida, Go Gators, national champions in basketball with an accounting degree.
I did not.
Yeah. So, what do you think? Is there one or two key things that you would say in the last 20 to 25 years that really put us on a fast track to where we are today? So profit driven, really ramping up utilization management, which means the insurance companies and or PBMs are putting guardrails around what physicians do and what patients are allowed to do. Is there one or two things that you would say, you know what, this really sped it up?
Yeah, I think two things. One, I love your phrase, don't blame the player, blame the game.
Yep.
The ultimate structure of the pharmaceutical drug piece of the healthcare system is driven by rebates. For any of your listeners who didn't listen to Dr. Maddie Feldman on your podcast, she did a fantastic job of describing pharmacy benefit managers and why the entire system is incentivized to have the highest possible cost drug, which is a perverse incentive, totally counterintuitive, but the way the system. And if you recall, back in President Trump's first administration, he proposed an elimination of rebates from the healthcare system, which basically says the pharmaceutical company should sell the drugs to the payers and PBMs at a net price. That caused so much havoc because it would disrupt not only the cash flows, but the earnings per share, the revenues, all the financially Wall Street driven calculations, revenue per quarter, earnings per share, all of those things would become so out of whack that the stock prices of pretty much all healthcare players would have plummeted. And so, that never went through. It potentially could rise again, but rebates are the crack of the healthcare system because every player becomes addicted to it. The pharmaceutical companies have to offer them to get access. The PBMs use it to make their profits. They share some of it back to the employers to reduce the overall employee healthcare costs. And if you take that away, the system just collapses under itself. So that's one big thing. I think the fast and expansive growth of rebates has created this perverse system where the lowest cost drug is not necessarily the one that gets utilized, that the patient has access to, and most importantly, that the patient ends up paying for.
Just so everybody here, and I know, in a previous podcast, Dr. Maddie Feldman out of New Orleans, she talked about this a little bit, but you brought it back up again. So just a reminder, the rebates are what drug manufacturers have to pay to insurance companies or PBMs to have their drugs on their formularies so physicians can have access to prescribe those drugs. And when you say, okay, well, how much can that be? Last year, I think that the pharmaceutical industry paid about $250 billion to insurance companies and PBMs. So these are big numbers. And to John's point, if you have a $1,000 drug with a $500 rebate or a $10,000 drug with a $5,000 rebate, they're attracted to that more expensive $10,000 drug. So I agree with you, John. It really, and that blew up around 2009, 2010 when I was doing account management. We used to only give them 1 to 3% of admin fee. And then, at the time, one of the manufacturers cracked, gave them extra money to be preferred. And then the arms race began.
Downward death spiral began. And the pharmaceutical company is its worst enemy because everybody plays along and, shoots itself in the foot. But the other big factor, which is very much related and contributes to it, is the consolidation. First of all, the combination of health plans and pharmacy benefit managers, and then the consolidation, basically the three combinations now, I think, cover over 85% of the lives, both commercial and Medicare Advantage and Medicaid, et cetera. So that consolidation gives them incredible purchasing power and leverage with the pharmaceutical company, which just escalates the amount of crack rebates that get into the system. So to me, those are the two big things.
And to build on the consolidation piece, and I know that we've seen, I think it's Adam Fine from Drug Channels Institute. He has the vertical integration slide, which shows the insurance companies that have either merged or been bought by pharmacy benefit managers, that then they get their own GPO or group purchase organization, their own specialty pharmacies. They're buying their own physician practices. They're buying their own hospitals, and up and down that food chain. They just really have consolidated a lot of power. And you brought up something that I don't think a lot of people realize, and that is that these private players, insurance companies, say United or Cigna or Aetna, they also play in the public sector space. I don't think a lot of people realize that they also are the ones that manage not only commercial lives for the employers, Medicare Advantage, and manage Medicaid. Because our legislators, and rightfully so, were like, you know what, the government's bureaucratic and clunky. Let's get innovative private industry in here to be more efficient and more effective. And I'm not sure that it's ended up how we had hoped.
No, and the other thing is that, the government entity said, look, we'll let them go do our dirty work, and we can add our significant purchasing volume to theirs, which makes even more leverage and more reason to escalate rebates and ultimately escalate prices.
So, John, I've had a number of podcasts, and I'm still a rookie, but I have talked an awful lot about the insurance companies and the pharmacy benefit managers. You mentioned hospital systems and the growth of hospital systems. And look, we all know that we need hospitals. I get it. But what is their role in this? Where do you see that? I always kind of laugh because hospital costs to our country have stayed around a third of healthcare expenditures in our country for like 40 years. Even with all the innovations out there that everything goes outpatient and you have drugs keeping patients in the hospitals, that cost has never gone down. What are your thoughts on the hospital industry and the consolidation of the systems?
Well, a couple thoughts. On the negative side, and this gets at me from my, you can take the boy out of accounting, but you can't take the accounting out of the boy. The whole hospital chargeback system from a financial perspective is crazy, right? You get charged $1,000 for a pill of Tylenol, right? And then, but the insurance company only pays $1.50 for it, but on the charge system, it shows it. So to get at what the true costs are is ridiculous. And it's like people buying a car. Some people don't realize that you don't pay sticker price, and they will do that. So hospitals can charge things, and the smaller insurance company, the private pay individuals will pay, that higher price. But the large insurers, the government, no way, we're not paying that. We pay 30 cents on the dollar. I was on a board of a hospital many years ago, and Aetna came in overnight and said, we're cutting our payments to you for everything from neonatal care to surgery to, emergency room visits by 40%, overnight. And so that shows you that, the leverage that they have. But some people don't have that leverage, and they get the bill. And none of us, I've been working in the industry for 40 years. I have an accounting degree. You send me an EOB, an explanation of benefit from a hospital, and I have a hard time figuring it out. And that's, I think, intentional, right? So I think that's part of the negative associated with that. I would argue that one of the positives, because I would not yes, is there consolidation in the hospital industry? Yes. But the better thing that's happened is integration. Hospitals now own physician practices. They own ambulatory surgery centers. They own freestanding infusion centers. And by doing that, I do think you get economies of scale. I do think you get a more intelligent, coordinated, optimized delivery of care, not only from a clinical perspective and a patient effectiveness, but also from a cost, and financial perspective as well.
So that's interesting. I love it, because this is one of the first times that I'm going to disagree with one of my guests. And so I would love this discussion. So I look at it differently. I do think that the coordination of care, I agree with you 100%. But we're losing our independent physician practices. They're getting bought up by private equity or hospitals, and for whatever reason, whether it's the high cost of administration or the older partners in these practices just want to be bought out and get their golden umbrella. But to me, what I see and what I used to hear from a lot of my medical societies is, these hospitals are coming in. Yes, they are buying up ambulatory surgery centers or physician practices. But then all of a sudden, a price that was at a physician's practice that you and I know was probably around average sales price plus 6%. So whatever, Medicare plus 6%. It goes to a hospital. They own it. Same doc, same location, same patient, same drug, same service, double, triple the cost. So is that wrong, or is that just one of not all the players do that, just some of them? I mean, because I don't like all the hospital consolidation. I like it from negotiating with the insurers. Yes, I know. You like that too. But as far as that losing that independent physician practice, that I don't like that piece.
Well, I think that's a double-edged sword. And I think, and I have a serious concern in this country about the future of our country and the world producing physicians, because it's not a profession that is as economically viable or successful as it used to be. Now, maybe you have a better quality of life because you're not on call 24/7 or whatever. That's a trade-off, and a lot of younger people prefer that. But it's not something you're going to get rich quick on, because it's your point. The hospitals are determining your salaries. But I would argue, back to understand the game, the hospitals are not determining ultimately physician payment. The insurance companies who are cutting 40% overnight are forcing that payment to get cut as well. I don't think, certainly physicians and providers, nurses, everybody across the board, they're not as profitable, is a bad word to use with them, but they're not as economically well as they used to be 20, 30 years ago. I don't think the hospital industry is as profitable as the insurance/PBM industry has been. I'm the Willie Sutton, why do you rob banks? Because that's where the money is. Follow the dollar. And the dollar usually ends up in the pockets of the insurance companies and PBMs. That's why, the book I'm proposing to write about what does PBM really stand for? It's profit-based medicine.
Yeah. Well, in my second podcast, that was the title of the podcast, which was Follow the Money. And you're absolutely right. I mean, I didn't even realize this, but I pulled up the Forbes 500 and I took the 5 biggest players of each, like health insurance, pharmacy benefit managers, hospitals, main drug manufacturers. Did you know that the 5 largest drug manufacturers combined revenue in a year is less than United's revenue alone? And the 5 largest drug manufacturers in the world's total revenue in 1 year is less than Aetna's total revenue in 1 year. So you are right. I think that all the players can get better. I think that the major money is in these insurers right now. But one thing, and we didn't talk about this earlier, so we'll wing it. You said that you and I are both pretty good at that. You mentioned about the physicians and that healthcare practitioners, it's not as lucrative as it used to be. So I remember when I started late 80s and into the 90s, I was doing orthopedic implants. I was doing, I was getting into medical equipment and supplies and a little bit of pharmaceuticals. But then that Stark Law came. And the physicians used to be able to okay, I have an imaging center or I've got my ambulatory surgery center and I'm going to send my patients there. And they kept a lot of that business and services and revenue. And then the federal legislators, the governor and the government basically was like, oh, wait a minute, docs, they're going to self-referral. They're going to send more services and get more labs done and get more x-rays done just so they can make more money. So they passed that law where they couldn't self-referral. And it looks like the insurers who do not have the Stark Amendment that applies to them, they've taken that to the stratosphere strategically. And they self-referral everything. What are your thoughts around that?
Well, first of all, on the physician side, and I know you know this because we did a lot of work with physicians who buy and bill. So they buy the biologics that they either inject or administer to patients in their office, and then they bill the government. And there is, a difference in cost and revenue there. And often that subsidizes the cost of their office staff, their office, their insurance, leakage, all those things. The government always said, which is why they always have all these proposals towards reforming that system, because they believe it's a perverse incentive. And in their mind, and I think this is a personal and professional insult to physicians, said that, oh, they're using the more expensive drug because they're making more money. We did a significant amount of research, third party, objective. That is not true. There is no evidence to prove that doctors use the more expensive drug because they make more money on it. And, that's like I said, I'm not a physician, but I have a lot of physicians that I worked with. Maddie Feldman, who you had on there, and I've had this conversation with her. That's really an insult to them. The fact that CVS now is an insurer, a pharmacy benefit manager, a retail pharmacy network, and also clinics, mini clinics, and all those other things. You can get in your entire healthcare and never touch anybody that's not employed by CVS. You could argue, oh, that's efficient because they can all look at the 2 point, look at the P&L, and don't look at the revenue, because the revenue is just a matter of aggregating all the different things. It's look at the profit. That is, I think, to your point, the providers who are truly professionally trying to do the right thing for their patients get accused and limited by, not able to refer to other opportunities and take advantage of other opportunities as business people.
Right.
Are now operating a system where the people making the rules don't have to follow the rules. And it's crazy.
Yeah, God, I love having a conversation with you, because you make me think of different things. But at the end of the day, you mentioned at the very beginning how not just in the States, but worldwide, a shortage of healthcare practitioners, of physicians, because really and truly they're becoming like almost like a commodity. I literally had he is a chief medical officer of a huge urology practice, one of the largest ones in the country. He basically told me that by the time they got reimbursed to do a procedure, it is less than like a guy to install a window at his house. And you're talking about the guy that's putting you under and doing surgery on you and either removing polyps or doing something. And to me, I couldn't agree with you more. It was so insulting to think that they said, okay, pharmaceutical reps can no longer take a pen or a pad or a mug to a doctor's office because that's going to influence them. At the end of the day, physicians are face to face with their patients. They are going to take care of those patients because they have to see them again and again and again. Somebody up in the C-suite, as you say, a bean counter, they never see those patients. They are immune and numb to the impact. So are there maybe some physicians who took care of the environment and the opportunities? Of course, you have that in every profession. But by and large, 99.9% of docs, they're good people, but they are really getting worked over.
But yes, and to go back to something I said earlier, I'm not a doctor. I don't play one on TV. Didn't stay at a Holiday Inn Express last night. And I haven't had this conversation, but I will, because it just kind of popped into my head. I would argue that young men and women are not going into medical school, yes, because it's not as financially, not even lucrative. It might not even be viable.
Yep.
But I don't think that's the main reason they don't pursue that profession. Okay. I would argue the main reason they don't is because, to your point, they're getting into it because they want to help people stay healthy or get healthy. And that is a science, but it's also an art. And even the science part requires experimentation, requires flexibility. And our healthcare system has taken all of that out of play. A physician doesn't have the ability to use his or her judgment, experience, expertise, creativity, and that sounds scary when it comes to medicine, but look, nothing new would get invented if there wasn't creativity.
That's right.
That is now 90% gone because of the formularies, because of the clinical pathways, because of all the procedurals that are required to follow. And if you don't, you get dinged on your payment. Nobody cares that, oh, you saved the patient or their health outcome was better. No, you used a drug that was not on formulary, or you deviated from, the procedure. So I would argue that that's as big or not a bigger contributor to why people aren't going in to practicing medicine It's almost like, following a cookbook. You've
Yeah.
heard the term cookbook medicine before. That's really what it is.
If you are a cook, a chef, you go into that because you're an artist. You're passionate about it. You want to be creative. You want to trust your gut instinct. That's what you train to do. Same with physicians. But if you have a restaurant owner that comes in there and goes, you know what? You can make grilled cheeses and tuna fish sandwiches and hamburgers. They're not going to work there very long. And to jump back real quick, we talk about this consolidation and how it can help. Someone told me a great metaphor the other day. They said, you know what? It's like if you wrecked your car and so you took it to get repaired, but the dealer owns the repair shop that you have to take it to. He also owns the property insurance that you're getting your car insurance from. And he owns the paint shop. So how do you know if you're getting a good deal if the dealer owns the car insurance, owns the shop, owns the paint? You have no idea. And trusting them is hilarious.
More importantly, not just the best deal. How do you know you're getting the right decision? You to stick with your example. You're taking the car. The guy would rather sell you a new car, so he tells the repair shop to say this is totaled. It's not worth repairing. Gives you a highball estimate, and entices you to buy a new car.
Yeah,
that's what our healthcare system is doing.
That is where we are at. So John, I tried to do this. My daughters who keep me in check, they're like, okay, Dad, you can rant, you can talk about how bad the system is and all that, but you also have to give people hope. That's one of the things that our group did is, we really focus more on state policy, although we also, had teams that did federal, but at least the team I was on was more state focused. I'm not going to get into details of that, but I see some things that are happening. I think you would agree 7 years ago, members of Congress didn't know what a PBM was. And fortunately, due to advocates and industry, they realize what they are now. Do you see some hope in the near future legislatively?
Absolutely. And that's partially why I want to write this book, to shed light. And by the way, the beginning of the book says PBMs were well intended and served a good purpose in the beginning. And once again, maybe not the player of the game, they've evolved into some of these things. And I think there's things been going on. What at the state level, as you know, we've been working, and the industry, but more importantly, advocacy groups, patient groups, provider groups, have done a great job over the years of getting laws passed at the state level. But rather than focusing on the PBM insurer as a business, focus on their practices, their step therapy, once again, listen to Maddie Feldman last week, things like non-medical switching, where they switch a clinically stable patient from one drug to another drug because they make more money on the other drug. I think when I left, we had 12 states that passed laws, to restrict or prevent that. Similarly, the copays that pharmaceutical companies provide to reduce the out-of-pocket costs for patients. The PBMs figured out a way to basically divert them into their pockets instead of the patients. So we had laws passed there. What I'm encouraged by is, first of all, kind of that groundswell. Once you get 10 or 12 states, you can then go to the federal legislators and say, wait a minute, why aren't we doing this? Why don't we stop closing the barn door before the horse gets out, or lopping the, monster's head off, whatever, analog you want to use or metaphor you want to use? Let's do some federal legislation. And there is federal legislation, the Help Copays Act in the Senate. There's other, legislation out there. So I think that's great. But what I also think is great, and they kind of dovetail in that now the PBMs are being scrutinized as an industry and as an entity. There is legislation introduced, I think, a few weeks ago to force them to unconsolidate and to decouple the insurance piece from the PBM piece. Yep. That's a good thing to the example you just gave with the cars, right? Also, Federal Trade Commission, has been, I think it's almost 2 years now, they've been investigating the practices. I always push for, don't just investigate the financial practices but also investigate the practices that harm patient care, the non-medical switching, the prior authorization, the copays, et cetera. But I think Now that they are being, and you saw a few months ago, all the heads of the PBMs were called in front of, Congressional Oversight Committee and put the spotlight on them. It used to be if you went in and talked to a legislator about a PBM or whatever, they said, first of all, they didn't know how to spell it. But secondly, they said, oh, you're a pharma company. You're bad. They're your enemy. They're good. Right. The enemy of my enemy is my friend.
Right.
Well, now I think they realize, okay, yeah, does the pharma industry have a lot to blame? But has the pharma industry now been called, with the Inflation Reduction Act and some of the things President Trump is doing, a lot of those abuses are now, under control.
Right.
I think now that policymakers are willing to consider PBMs in a different perspective and say, okay, maybe they are the bad guys too, because those pharma people, even when we took something out of them, the prices aren't going down.
Exactly.
I think we plugged the wrong hole in the dike, and so I am hopeful for that. And I'm also hopeful because I think politicians have become more aware over the last 5 to 10 years that patients are also voters. And if the patient can voice their concerns in the context of this is important to me and this will determine my vote or could determine my vote, that is powerful. And that's at an individual patient level. And then there are abilities, there's, patient advocacy groups, provider advocacy groups are continuing to grow. We're seeing now coalitions to say, oh, these poor practices like non-medical switching or copay accumulators, they impact oncology patients, diabetics, mental health patients,
Everybody.
cardiovascular patients. So now we can bring a coalition of not only patients, but providers together. And J&J, we were one of the first companies that started to be that convener,
right,
to do that. That's powerful because then it's not just, oh, this is an oncology issue or this is a mental health issue. And you got to go to the legislators that have a receptivity to that thing because of a family situation or a personal situation. No, now you can say, look, this affects everybody. Long-winded answer to your question, but yes, there is hope. And the hope is that patients need to get involved, need to understand, learn more about how the system works. And it's, as President Trump said, who knew healthcare was so complicated? Yes, it's complicated, but podcasts like this that try to educate people, I always like for your listeners, a great place to go is the Kaiser Family Foundation website. They do a great job of taking complex things and making them understandable. What was the old cartoon about how a bill's made? Something Rock, Schoolhouse Rock.
Oh yeah, Schoolhouse Rock.
They don't do it in, well, sometimes I have seen cartoons there, but they are really good. And if you, as an individual, not somebody who's a provider or an employee of a hospital or a farm, but if you're just a consumer of healthcare, that's a great place to go to understand. You see something on, on TV about, pharmacy benefit managers or how this is going to change your benefit. Go to the Kaiser Family Foundation. And I don't get paid, by the way. I have no affiliation with them.
Right.
That's probably the best source to get I don't want to say boiled down, a simple, easily understandable, user-friendly explanation of how things in the healthcare system work.
Yeah, John, thank you. And it's interesting. And I do have hope too. If for at the very least, the mainstream media and the politicians are talking about this. And to your point, like the drug manufacturers, they definitely have a role to play in this. At the end of the day, they set the initial price, and we got our good and bad players. But I think that legislators feel like, okay, we've taken our pound of flesh. And to your point, nothing has changed. So who else is making a lot of money? And like I did in my second podcast, if you take the 5 biggest insurers, their revenue in 2023 was 1.2 trillion with a T dollars, 5 companies. So they're doing something as far as follow the money. Deep Throat, Watergate, you have to follow that money. But you said something, and I really want to finish our discussion with this, is that there is momentum. The legislators, do they get a lot of money from these huge corporations? Absolutely. But to your point, when a staffer of a legislator or a federal or state legislator gets a call from a patient, from a constituent, that holds so much weight. They know that you're talking to your neighbors and to your families. And so, John, I don't know if you've had a chance to go onto my website, I really kind of cheated from my old job and looked at different websites like CSRO has a great site and all these. But I have, and it's my passion, is I've got a section that you could click on, and if you put in your zip code, you can find your legislator, who your federal or your state legislator is. I have templates that talk about issues like, say, you mentioned non-medical switching, where an insurance company says you have to go off a drug for non-medical reason. There's a template letter in there that tells you about that. You can add your story and send it in, or just make a phone call. But John, just maybe we could finish the podcast, because I know that people go, this is so complicated, and that's by design, as we have said. And what's my, just little old me, that's not going to make an impact. Help everybody realize that, yes, it actually does.
It absolutely does, because having spent time in legislators' office at both the federal and state level, their staffs, they'll walk in from a meeting or whatever and say, what's hot today? And they'll say, well, I've gotten 37 phone calls about this, or here's a stack of letters about that, or you got this many emails about this. They do listen, they count. And I think the other thing that's important is, look, as we can tell, we are more divided politically as a country than ever on so many different issues, right? The one area where Democrats, Republicans, liberals, and conservatives all agree is that we spend way too much on healthcare in this country, and that people are being forced to make choices between food, education, vacations, whatever, and not just their medicines, their overall healthcare, going to see a physician, going to an emergency room when they really should, etc. That is a bipartisan top of list issue. Don't worry whether your legislator is a Republican or a Democrat. They will listen to your concerns about your health care.
And thank you. I mean, and you've heard this years ago. We would go to a legislator and we'd say, this is a major issue. And sometimes they come back and say, no one's called my office. No one told me that. And people need to realize you have power. And to your point with the Kaiser Family Foundation, which is one of the sites that I go to a ton, Drug Channels Institute, Endpoints, there's so many great sites out there. But we've got the Google and we got ChatGPT. If you're like, you know what, I don't believe Hoffman and Melindy, I'm going to look this up. Type it into Google. We have so much information now. Just when you're sitting there on your phone watching your kid play soccer and you're bored because they're on the bench or it's a soccer match, they're going to score 2 goals the whole game, look some of this stuff up. It is empowering, and you may not need it today, but we're all going to be a patient eventually. Everybody's getting impacted. So, it's up to us. It's up to us. John, anything that you want to leave the viewership with?
Just don't give up the fight. The patient voice is powerful. And one of the things that I've been saying and hearing a lot from people as we talk about all the challenges that our country faces, sitting on the sidelines and watching is not an acceptable approach. If you're not part of the solution, then you're part of the problem. And the way you can be part of the solution is get involved, get educated, get vocal, get involved.
Well, John, I got to tell you, your advocate for access jacket, you look like a physician right there. So I'm a little bit intimidated. Fortunately, I know you. But with all joking aside, it has been awesome to connect with you once again. Appreciated our years working together. I'm going to look up your white paper. Can't wait to see your book. And I'm sure that the companies that hire you, they're going to get some really good expertise because you did amazing things when we were together for a long time.
Well, I want to say thanks for having me on. Thanks for giving me the opportunity. But more importantly, thank you for doing this. I know why you're doing this. You're doing it because you want to make a constructive change to something that needs to be changed. And that's why I'm, doing some of the things I'm doing as well. So I want to applaud you, commend you, and congratulate you for having the vision and the commitment to do this. So,
well, thank you. But John, we'll raise our glasses. We're still semi-retired, and I'm going to work on that golf game and get my handicap below a 20. Take care, brother.
All right. Bye.
Bye.